Okay, we're talking about kidney cancer. It's the kidney cancer session. We're excited about this. You know, Brian and I wrote this section together with the help of many other people, and it was going to be a slightly unexciting section. I've talked for a long time about this plateau of kidney cancer, and that we're not making as much progress as we should, and that I couldn't see a way through the problem. And then a couple of weeks ago, a couple of press releases came out, and with 2 positive trials in kidney cancer. And we're going to discuss today a lot about both. We don't know the results of the studies, obviously, but we're going to talk about how that changes our concept of the disease, firstly. And then secondly, towards afterwards, Brian and I are going to talk a little bit about some of the newer therapies, including the VEGF PD-1s in kidney cancer, but also in other areas, and John's really kindly joining us. I'm Tom Poles.
I'm Cristina Suarez from Barcelona, Spain.
Hans Amas from UT Southwestern.
Monty Powell from City of Hope.
Tony Schwery from Boston.
So this slide is an adjuvant kidney cancer slide, and I think it's an important slide because there was one outstanding study amongst the other 3. And Christina, we'll start with you. How do you approach this? Clearly, there's one study that has overall survival with adjuvant pembrolizumab with attractive hazard ratios. Tony, you led that work. But there are other studies there, including an Ipi-Nivo trial that's not worked. We've included the neoadjuvant PROSPER study on there as well. Prior to ESMO, what were you saying to your patients about this inconsistency?
So I think there are like some difference among the trials. So starting with the Emotion 010, I think Atezo is a PDL1, so this is a I think it makes a difference in RCC. We were never able to demonstrate OS with PDL1s in RCC. So this one may be one of the reasons, I don't know. And for the Checkmate 914, that the duration of the treatment was only 6 months, so maybe this could have a role. And in the new adjuvant Nivo, I think it's also the same, maybe the duration of response. But yes, as you said, that was before ESMO, because we have now another more or less positive trial.
We're going to talk about that in a second. But before we do, Monty, I'm going to jump to you, if I may. Monty, in terms of the Keynote 564 study, the study shows, I'm going to say, a 10 to 15% chance of life-changing toxicity. It shows about a 5% improvement in overall survival. The hazard ratios are attractive, both OS. In fact, the OS hazard ratio is lower than the EFS hazard. The EFS hazard ratio, I think, is 0.66 versus 0.71. You've got a really clear signal there, and it's FDA approved. Which patients are you giving adjuvant pembro to?
Yeah, everything that you just mentioned there, Tom, sort of informs the discussion with patients. And I think that really after a fair and balanced conversation, absent any obvious contraindications, I think most of my patients are opting to receive it.
Is grade or is T-stage more important to you?
I think, both are relevant. Maybe T-stage might sort of trump that to some extent. If I see a T4 patient, rarely would that be low grade, but I do think that would be a strong influence in me sort of pushing the envelope a little bit with adjuvant treatment.
Tony, when you designed the trial, how did you select these patients? Because it wasn't the Liebowitz score, it was a new scoring system. And well, I'm not going to show a forest plot analysis now. There were some M1 NED patients. If you remove those, the benefits remain. The T3 patients, which was the majority of patients, the benefit was clear. The DFS and the OS signal are quite consistent across subgroups of patients. It's quite hard to pull out subgroups. Hans might talk in a minute about things, and I'm going to come to you, Hans. I know that I'm doing it on purpose. Tony, so how did you select patients for this study? Was it logical? And are there any subgroups that we need to think about differently that we include in the trial? Or is it just, Tom, it's a positive trial, move on?
You really need to move on. But I'm going to go back. It was extremely logical that we know, playing Monday morning quarterback, all the subgroups, how we looked at them, they were logical and met, almost the same hazard ratio as the overall population. We said to ourselves, we need to be pragmatic in oncology. And when you have this pathology report, in general, if you are in Boston or in Texas or in Vancouver, what do you put in it? And at that time, when we designed the study, we found that the T stage, not even the tumor size, we found that the grade are universally put in, not the tumor necrosis route, not the sarcomatoid feature, not many things. And based on that, tumor necrosis put in maybe 30%. Now it's different. So based on that, we said we have to have a system that include TNM and grade. Do we lose a lot by not having the tumor size or the tumor necrosis or thing? Actually, no, because while we were doing the study, Assure and Bob Uzo, our good friend from Philly, came up with a look to all the nomogram through Assure, an adjuvant study with sunitinib, sorafenib, placebo, and found that all of them provide very little increment, maybe the same as TNM stage. So we thought we're safe. And with including M1 MED, especially with our Italian friends, I don't know if there's any Italians here, real Italian, not Italian-American. There is some, they started doing M1 and ED with TKI, we included that. So in retrospect, it was good. Remember also, all these other nomogram, none of them were done prospectively and validated prospectively.
Hans, you and I have disagreed on many issues in our lives. We've disagreed on concepts of this study. Do you want to just talk through your mindset about where you are with this environment? And I'd like it to be pre-Rampart, please.
So, to me, so when it comes to patients and the adjuvant discussion, I try to present the data relatively balanced, which is that they have a certain chance of reducing the risk of recurrence, right? And then we calculate actually and explain relative risk reduction versus absolute risk reduction in their particular case, and then I also balance that with the potential side effects, and that let's say somebody with an average risk of 30%, that 70% of the time they never needed the risk of these particular side effects, for example. Or somebody has a 50% chance that they will have a higher risk of recurrence, and they may need to balance that with these side effects. I tell them that I'm not yet convinced that there is an OS benefit, in particular if you have access to immunotherapy, meaning it may not be as relevant for the US population to talk about, hey, you're going to live longer if you're going to be on this therapy because it's so much more effective in the early treatment space. I tell them there are some questions about the trial and the data sets that led me to believe that this might not be the answer, so to say. So I focus on DFS, and I focus on really the pros and cons of getting into immunotherapy early versus delayed.
And I guess, I guess one of the issues is from my perspective is achieving significant overall survival from a statistical perspective in a 1,000-patient trial. It's actually quite hard to do. And the fact that it's achieved that goal in a global trial, in the knowledge that although, in animal models we'll always get everything if you keep people in a cage and you could get subsequent therapy bin, but in a country like the UK where you have free access to immune therapy, we'll even take patients to the hospital free of charge, the uptake of immune therapy in metastatic disease is about 60%, 60. That means that, and we know in good risk disease from an overall survival perspective, sunitinib's never been outperformed, and many of us in the room will be giving, let's say, stereotactic radiation therapy or other treatments, and then of course there is subsequent therapy is conditional, so it evolves with time. What sort of level of immune therapy would you be happy? What do we need to see to make you happy? I know other people might feel different.
But first of all, I think it's important to think about the context, right? So number one is there are not that many adjuvant trials with immunotherapy that have ever shown OS benefit, right? So this is an exception here. The other one is that in principle, the other one is, if I may say, is that in principle, immunotherapy is curative potential no matter when you give it in the treatment course, right? That's why we are now median overall survival 4 to 5 years, right? So it does have curative potential. The adjuvant space was important in the chemotherapy area in particular, because you used a chemotherapy form that didn't cure anyone in grossly recurrent disease, but was curative in micrometastatic disease. That's how it all started. And that is not necessarily true for immunotherapy. So in principle, it's an uphill battle to show OS benefit in my mind. And so I think, the question is, what have you actually shown? With this trial, what you have shown is if you treat 400 people with immunotherapy in the one group, and in the other group, just half of patients potentially with immunotherapy, that you see an OS benefit. And that's fine. I don't have a problem with it. I'm not saying that we didn't observe an OS benefit in the trial. The question is, how does it apply to my patient who has access to immunotherapy at any time in the treatment course? And that data set doesn't help me with that discussion with that patient in my practice.
Tony, far away.
About
Do you want to say something?
Yeah, I think there has been an argument, made, and it's not a, good argument, that patient on the non-pembro arm didn't get immunotherapy. Well, there are problems here in this argument. First of all, patients do not need to get all immunotherapy. These are patients that already have one less IMDC risk score because they weren't diagnosed with metastatic disease. Some of them, I would say, and we have that in the supplementary table, many table of the publications, and we have you and I and few others in editorial about this in Lancet Oncology. Some of these patients gonna have single agent TKI, which is used, at that time in favor risk. Some of these patients gonna be observed till the metastatic disease declare itself. So this is, relapse, but doesn't need an IO yet. And we know with time, when you do several data cut from the trial, the percentage of IO increased. Other patients would need surgery and or radiation, and some of them will get immunotherapy. The other thing is the patients were treated at centers that are, were vetted clinical trial centers. These patients, physicians that has been doing kidney cancer and doing trials, etc. They have resources. So saying that, you weren't because your country doesn't have immunotherapy is actually not true, not realistic. It's not the case.
Yeah, I mean, to me, it's really more about, did we truly answer the question if immunotherapy is more effective in the micrometastasis space versus recurrence? And I don't think that trial answered that per se, right? That's really what it implies when you talk about an OS benefit, is that if you give it super, it's going to be more effective than later. And I don't think we answered that with this trial.
So, Hans, is there another study out there? What is this? Because I think all the other tumor groups, you'd look at this and say that's a survival benefit. Certainly the bladder group, the adjuvant pembrolizumab, and adjuvant nivolumab in bladder cancer, they've not achieved that survival goal. Yeah, when you get a room full of people like this and you ask the school, even without overall survival, in the US, there's a strong recommendation to give it. And indeed, it was seen unethical to randomize in the US patients into InVigor 11. The US sites found it unethical because we weren't giving a drug that didn't have a survival benefit. And now we've got it. And you're saying, you know what, I'm not sure. And that's, that I find I struggle with it.
Okay. So for me, it's, all I'm saying is there is value in adjuvant therapy for certain patients. And to me, it's still a risk-benefit discussion. I don't strap them down and infuse them personally. So it's really about a balanced discussion. It's not true that we cannot cure patients when they recur, right? That's the power of immunotherapy. What the trial has shown is that if you get access to immunotherapy, you're going to live longer, for sure.
But having metastatic...
But the other thing also is a data set that we have asked for is of the patients who died, how many actually got immunotherapy, right? That would help us with certain biases and better understand.
But having once you've got metastatic disease, you're on lifelong therapy, and almost all of those patients die. That's not an attractive place to be. Saying patients, don't worry, metastatic kidney cancer is okay.
So we cure some patients with recurrent disease, right? Don't you think so? You don't think so?
We cure some patients, but
So you think even if you have the only
if
curative
you see a
in the
metastatic
micromesothelioma
kidney cancer patient and said, I'm likely to cure you, I don't think that's right yet. I wish it was to change.
Yeah, I would argue that if patient relapse and didn't get immunotherapy is because they didn't get immunotherapy in the adjuvant setting, because they relapsed with such a horrible disease, brain metastasis, complication, DVT, that you missed the window, and you're not at the bedside to give immunotherapy, one. Second, if this was done in breast cancer or something dear to our heart, bladder cancer, this will be no discussion. Nivolumab was accepted without an OS benefit and nothing even close to a hazard ratio like this with a DFS. I haven't been in discussion where people pushed so much against nivolumab, except and we had another atezo that was negative. So why this? I mean, we already are the disease that are funded the least.
So 50% of my patients in my practice choose pembrolizumab, and I give it to them. It's not like I'm against adjuvant therapy. I just don't use DOS as the main argument.
That's a great progress. Congrats.
Hans, firstly, you're very welcome here, and without you, the discussion would be less rich. Okay. So we move on to the Rampart trial, which is a study which we were involved with at our center. It's an investigator-initiated trial. It's a randomized phase 3. It is durva-tremi. It's also in a high-risk group. It's using the Leibowitz score for what it's worth. Actually, when you look at the Kaplan-Meier curves, the risk group in terms of the relapse rate in the control arm wasn't quite as high as some of the other trials. So while it looks like high-risk patients, actually the real mark for your risk is not your T stage at baseline, but your relapse rate at 48 months. That tells you what's going to happen to the patients. And this group of patients, for whatever reason, did slightly better than you might have expected. The trial was closed a little bit early because pembrolizumab was approved, even in the UK, demonstrating how marvelous it might be. That's a joke, Hans. It's a joke. I won't be, so it was approved by NICE in the UK, and so we had to close the study because the control arm was no longer deemed to be ethical. And so the study read out, and the statistical analysis plan, because it was underpowered, the statistical analysis plan said we're going to combine our alpha rather than split it, which meant that because the numbers were smaller, we could actually test it. So we said we'll test the combination first, which is why you've not seen the monotherapy arm yet. It's not that we don't know it's not that we know the result and are not showing the result. And this is an interesting observation, I think. And this was a stratification factor. So I think when we decide stratification factors, we do to some extent need to take those subgroups more seriously than stuff picked out of the randomization on a Thursday, whatever it might be. Monty and then Chris, talk to me about what you first thought when you heard that Rampart was positive. Before you say anything, I'd like to say two caveats, if I may. It includes a non-clear cell subgroup, which is quite a lot of patients, and we have not yet seen that subgroup. And it was investigator assess open label. It didn't have a central review and didn't have a placebo, and investigator initiated open label trial. There are reasons why, and I think if we wanted to get approval, we probably would have to do a central radiology independent review. Far away, Monty.
Yeah, I think first off, it came to mind is that, in isolation, obviously any, positive trial result is something I'd look forward to. But I think that, with your work with Tony on 564, I think you've really sort of raised the bar for us. So, my immediate thoughts went to, are we seeing any hint of an OS advantage here? What does the tox profile look like? Is it anything comparable to single agent pembro, which you wouldn't anticipate for a doublet? But, those were the immediate questions that I had, I suppose.
Chris, Spain also took part in the study. Talk to me about the intermediate and the higher risk subgroup. Is that something which we didn't see this in 564? The intermediate risk disease-free survival is exceptionally good. Very few patients relapsing in that arm. Do we need to look at our classification and the way we stratify patients differently based off this? Or is it just that we just don't know enough about risk in these patients?
So I don't know. I think that it's clear a signal here for high risk patients. Like the hazard ratio is very very good. So it's different from the inclusion criteria were different from the keynote. Like they were using Libovit. So maybe it's a matter of the selection of the patients. I don't know, but I really think that if we didn't have pembrolizumab, I think in the high risk population we should be using durvalumab.
You asked me early on if what we came up with the keynote 564 were the right, and we know now, again, playing Monday morning quarterback, they were the right, because even in our intermediate high, the hazard ratio was 0.68, and it was statistically significant, clinically relevant, while here in the intermediate risk, you expose patient to a therapy that is toxic with a hazard ratio of 1.19. So I don't know the upper limit of the confidence interval in intermediate, but there could have been an excess of mortality of 40% in giving an intermediate patient durva and tremi. So I think going forward, keynote 564 criteria should be the one.
One question: Do we know how many non-clear patients were in this high risk
I
group?
don't know the answer to that question.
But mortality and recurrence is recurrence, so it doesn't matter in this. The other thing is, I think this is a good thing that we have another trial that is positive. We know that Nivo-Ipi was negative, so those are the kind, but it was 6 months, so this is a different study. Maybe we need more. And what
But there was only 2 cycles of durva. It was a bit eccentric in that respect. It wasn't.
well,
Hans, don't worry, I'm coming to you. Don't worry.
right, but Hans,
Don't you worry, Hans.
a touch of CTLA4 may be enough sometimes. A touch. The other thing like this, the other thing is we're going to wait on the single agent durva arm because it's possible.
Okay, Tony.
that-
Okay, Tony.
Don't you
Single
think?
agent durva. Is this all being driven by durva or is it durva tremi? I know you don't know. Just guess for me. Pluck it out of the sky. Where the durva comes out, is durva going to be positive in this trial? Yes or no? Positive durva.
Durva only.
Durva
Driven
only.
by durva.
Positive or no? Positive. Yes.
Positive.
Positive.
Yeah.
Yes.
Positive.
Probably.
What? Positive. What?
Hence, we converted you.
A single agent durva is going to be positive. Hans. But Hans, you're.
So I don't know if it's going to be so.
Guess. I guess.
Hempo had a chance to be positive too, right? So
Okay,
so
why was-
any agent has a chance to be positive in this?
Okay,
case.
I agree with that. Hans, why was the Ipi-Nivo trial negative in this space?
I don't have the answer. That's the simple truth. Nobody has the answer, but there's a certain probability that a certain trial is positive by some selection that we are not really good at. It's clear that the tendency is the
Yes.
higher the risk, the better you're going to do in a clinical trial. If we had better markers, circulating tumor DNA, we would tease them all out, right? So the problem is,
It's biology.
it is biology, it's patient selection.
Yeah.
We are really not good at it. The trend is the higher the risk,
Yeah.
the better you're going to perform with any drug,
To
with any
some
immunotherapy
extent.
drug,
To some extent.
with any drug.
Because to some extent, I mean, I think a football-sized cancer.
If I'm going to add something, I actually like this data. And the other thing we haven't talked about is for people like me who like the doublet a lot for metastatic disease,
Yes.
I have this anxiety that I undertreat some patients with single-agent pembrolizumab, right? So if I had a very high-risk patients that let's say we can find somehow in this trial or with Keynote 564 criteria, then I would love to actually give the doublet, right? So for example, if it's a sarcomatoid features or anything, right? I do believe that the CTLA4 component is important in those patients, and I may then select a Rampart regimen
Yes.
over a Keynote regimen.
And we don't yet know that this supports CTLA4 because it could be the durvalumab driving this. Now, it comes to an important issue, Hans, and I know I am going to come to you on this. And again, the conversation is richer for your presence.
Okay, great.
Okay, so here we go. So the 8-White-8 trial is Nivo versus Ipi.
Oh, you love that trial.
I love the trial.
You love it.
It's the ghost trial.
It's going to be the answer for everything.
So it's a trial which opened many, many years ago. It had response as its primary endpoint. If it had hit that, we would have known about it. And it had then moved to PFS. And clearly that trial, for whatever reason, hasn't shown that Ipi-Nivo at this point is a lot better than Nivo. It's had a minimum follow-up, I don't know, of 5 years or something. I can't believe it's a 20-year trial. So that worries me that Ipi-Nivo is not clearly better than Nivo. That worries me a bit, because if you've got an overall survival advantage with Pembro, which is great. You haven't got it with Ipi-Nivo in a similar setting, and you've got a study doing Nivo versus Ipi-Nivo. And we don't know the result of that trial, but I'm sure it's going through endpoint. If you look at clinicaltrials.gov, it's changed. The bankers phone me from time to time, and they look when people change their numbers on clinicaltrials.gov, and this trial has done that. And so that's not working out. Is there any doubt in your mind that actually the IPI actually isn't doing very much? Yeah.
I think the IPI is an important component for metastatic disease. The doublet that has shown the single best outcome for long-term outcome in patients is nivo-ipi, period. We know from several independent trials that a re-challenge with a CTLA-4-based regimen can induce responses. A very recent data set, Keymaker 03B, right, with PD-1 CTLA-4 Merck, showed a 30% response rate in patients who progress on PD-1. So do not tell me that CTLA-4 is not an important component in patients.
So I'm gonna stop talking in a second, but I feel the same.
You feel a lot.
I'm actually quite an emotional person. Todd.
You're very emotional.
I'm trying to be emotional. But this isn't about my personality so much. I probably use as much ipi-nivo as you use adjuvant pembro.
What does it mean?
It means that I think it's a great.
You don't use Epinivo.
Well, you tell me you use quite a lot of pembro, but you're happy to push back when we say it's amazing. And I'm the same. I'm very happy using ipi-nivo, but I push back a bit when people say it's clearly the best drug we have. And I think those are the positions where I stand. And I think you and I
Sounds good.
we end up in similar places, but disagree on how we get there. Chris, you were involved in this study. What do you need to see in Europe to give durva-tremi to patients? It's a European trial. I'm sure the European agencies would like to see a positive trial in Europe, and it'll come off patent one day and could be. Is this a regime that you would use? What else do you need to see? I'm guessing you could tell me what you need to see from this trial to be convinced that durva-tremi is doing something.
So I think what the easiest question is overall survival. I would say, like if I didn't have anything else, that would be that would be enough for me. But having pembro, it's difficult to beat pembro with no OS and more toxicity. So I don't know. And then again, I would like to see maybe in non-clear cell. So maybe this would be enough in non-clear cell because we don't have data. So. And I have many patients with non-clear cell that we can, at least in my country, we cannot offer adjuvant pembro. So I think maybe would be a good option for non-clear cell RCC.
Let's go non-clear cell right now. Anyone giving adjuvant therapy to non-clear cell on the stage?
I am.
And
Appropriate, discussion.
Well, what does an appropriate discussion look like, other than we have absolutely no data? We're throwing cards in the air.
Oh, it's a discussion.
And I've got no idea what's going on. But what is that? Just talk me through that. I'll be the patient.
So it's a discussion that doesn't have swears.
Yeah.
I think that will be appropriate. No, we have to. I'm going to give you something, and you tell me if you're not going to give them. So someone come with papillary, type 2, high grade, N+, 40-year-old,
Yes.
4 kids.
Yes.
The recurrence rate with any nomogram is between 80 and 95%.
Yes.
Nivo-ipi, at least in the adjuvant setting, in clear
Why not
cells.
chemotherapy? Why not chemotherapy?
Chemotherapy
Well, it's got the same data.
doesn't work in renal
It's got
cells.
the same data.
4% response rate.
Yeah, I do.
So, but
Yeah, just-
David McDermott.
Oh, what about
before he-
bevacizumab?
Look,
That might
David
do. That-
McDermott is
well,
looking at you. He did
What's
a
that
study.
estrogen drug? What's that?
He
What's
did a study.
tamoxifen? That's
So
racially
let's
cited.
agree here that these
Very
patients
exciting.
likely have metastatic
Tamoxifen is the
disease.
agent.
McDermott, Keynote 427, papillary RC, single agent pembro, 31% response rate, brother. So, or 25% papillary. So I think it will be very hard to not give it. I discuss it. They say,
Very
what's
hard
the
not to
evidence?
give it.
Yeah, what's the evidence? I say, look,
very
this
hard
is
to
it.
give it. I mean, it's very hard to push back strongly on hands. Yeah, on the one hand,
very, very hard.
and then Tony to
Yeah,
accept.
but
to
this
accept
is not
adjuvant-
chromophobe. This is a tumor that potentially is hot.
Okay.
And you explain with the patient. I'm not going to say, I'm saying, look, this is the evidence. It's coming. What do you do? There's no trial.
I'm fine with this, but I'm going to talk about papillary renal cancer, if I may, for 2 seconds. Monty, ipi-nivo in papillary renal cancer. Specifically didn't ask hands.
Yeah.
So, Monty, papillary renal cancer, ipi-nivo, sunny forecast. It's
Yeah.
a positive trial.
Okay.
So it does support Tony's hypothesis. You've got a positive immune therapy trial. Is Tony right that there is a strong papillary signal? And what do you need to see to use papillary renal cancer, pembrolizumab, for example?
Yeah, no, indeed. I mean, I think that sunny forecast opens up a whole can of worms, doesn't it? Just based on the endpoint in that study, et cetera. But I'll just put that aside for 1 second and just say I do tend to differ a little bit from Tony there in the sense that I'm a bit more of a purist and, kind of look to his design, your design of 564, because I'm not seeing, any sort of non-clear cell data there. I still hold off.
You didn't ask me.
And I didn't ask you because I wanted to give you a bit of a breather because something terrible's coming up in a minute. I've got a couple of really difficult questions, and I know you're going to get upset. So I thought we'll go through all that one. But if you want to, I'm going to move on, Hans. I'm going to move on, if I may, because we saw this press release, and none of us know the data, and so we are purely speculating. Monty, can I start with you? What do you think the chances of Bell? Because we've got a history of VEGF-targeted TKI therapy. Now, shoot me down if I'm wrong, but response rates for single-agent VEGF-TKI therapy are higher than response rates for belzutifan in metastatic kidney cancer.
Yeah.
And therefore, you would guess that a belzutifan-like drug would may be less active than a VEGF-TKI. The VEGF-TKI adjuvant story has been poor and has not resulted in any survival signal of any suggestion or any trend at any point. Even the S-TRACK trial, absolutely no survival trend. Assure, the biggest trial with sunitinib was spectacular, with sunitinib and sorafenib, spectacularly negative. Was this result a surprise to you? And if not, why not?
I was thrilled to see this. I mean, I will say that, belzutifan is one of those drugs that I think gets easier to give as you move up in line of therapy. Maybe not so much with TKIs, right? I think that remains challenging across, lines of therapy in most cases with many of the drugs from yesteryear, especially. My observation on this study is that, for the patients that I've treated to date, I mean, it was easier to kind of keep them on, right? I think that adherence was a big issue when we were trying to, get a patient through the slog of a year of sunitinib or sorafenib. Here, I found that, patients who I suspected were on the experimental arm were largely able to maintain dose.
Hans, what I want to hear from you, and this is a key question.
Key question.
Absolutely. Because you have an opinion which I haven't asked you this question, and we've discussed many things before. We haven't discussed. What do you need to see to give this to your patients?
So let me say two things about belzutifan in this context, which are interesting, and I'm torn about this trial, and I have to look at the data set very carefully, to be honest with you. Two things. One thing is that belzutifan, in my book, is at risk of diminishing the antigenicity of the kidney cancer by de facto reducing human endogenous retrovirus expression and may actually interfere with immunotherapy. On the other hand, it is actually an interesting agent. It's different than a VEGF TKI because it has a direct anti-tumor effect, and it may follow the logic and the experience that we have with chemotherapy, where it actually may have an activity against kidney cancer cells in the micrometastatic disease space. So these are kind of like the two things. It is different than the VEGF TKI, and I would not equate it with it. It can have a direct anti-tumor cell effect potentially in the micrometastatic disease space. However, I think it can also interfere with immunotherapy. So my fear a little bit is that we may see some benefit in the early readouts of the trials, but that the long-term outcome may actually be negatively affected. So I'm a little bit hesitant about any combination of the HIF2 inhibitor with immunotherapy. So these are my initial fears.
So you can see positive components, you can see some concern.
I do.
So what
did you see the data?
So what do you need? Let's say, and I don't know, but let's say
I need to see no concern on later outcomes, meaning OS curves, longer PFS curves.
So let's say I genuinely don't know what the data cut is in terms of the years, when the follow-up, etc. Let's say they've got 3 years median survival, and then what hazard ratio for DFS do you need to see, and what OS do you need to see to say to your patients, let's say assume it's FDA approved, What are those two numbers from your perspective?
So if there was an OS, it would be actually very interesting, right? Because belzutifan is an agent that we would not expect an OS with, because an OS benefit from, because it has never shown an OS benefit.
So
right?
OS trending the right way would be positive for you.
What, sorry?
OS trending the right way would be positive for you.
I think it would be positively surprising to me,
Okay.
and maybe I didn't give the drug a fair shot.
Okay. Monty, let's hear the same from you, please.
I'd say, hazard ratio for DFS 0.75, or below. And I would say for OS, I mean, you need to produce something that's, respectable for me to say this is a slam dunk, should be used in every patient. So, something in that 0.75 ballpark would also be very encouraging. Now, having said that, I would be prepared to consider this strongly, even in the absence of an OS survival benefit, if it was trending in the right direction.
And Chris, what would the Europeans and the rest of the world look at? What would the EMA's perspective be on what would they need to see to approve this?
So yeah, EMA is hard to discuss with them, but I think in the absence of OS, it's going to be a hard discussion. So you really need to see a good signal in DFS, like I would say 0.6, 0.7, or something like that in the absence of OS. If you have OS, then the discussion must be different. The good thing, I think, is that it's not going to add too much toxicity. So at least you can have this argument.
Here we've got some of the VEGF stories that we just talked about on this slide here. Here are the negative studies which we have looked at with VEGF TKI therapy, and the one positive trial with Assure, which was negative also for OS. There was a bit of a story on there in the pazopanib trial. And Monty, did you lead the pazopanib study?
No.
Oh, I thought it was you.
No.
Oh, shit. I'm going to tell people it was you. So in the pazopanib study, the original design, I think, was 800. And I remember I did one of the worst decisions I made in my career. I was asked for advice. We were struggling with transaminitis early on. Patients struggling with transamin, many coming off therapy, more discontinuations than we hoped for. And there was a long discussion about whether if we reduce the transaminitis, more patients continue on therapy. And this is how spectacularly wrong you can be, because you can see the 800 was going in the right way, the 600 wasn't. I wonder, maybe, is there a VEGF signal there, but we just haven't quite got it right in the adjuvant setting yet? Is Hans right that the direct effect of belzutifan, its distinct action, may result in this different result? Or actually, are we expecting an Assure type result? And if we get an Assure type result, would you just say, you know what, we didn't like Assure, and therefore we shouldn't now like belzutifan? None of us liked Assure. The FDA approved it, but no one gives it. So S-track, apologies, S-track. So S-track, the positive sunitinib trial without OS, none of us supported that. The FDA approved it. It's not widely given. Are we holding belzutifan to the same standard?
Yeah, I mean, I have to tell you, I think that, administering sunitinib, which, I've done in the context of studies, and, administering belzutifan, again, in the adjuvant setting in the context of studies, two different ball games altogether. I have to say, I'm super excited, and I hope we can all band together here in this room to support and get Brad's trial, Strike, across the finish line, which is looking at adjuvant tivozanib, shorter duration, I think 6 months, right, plus pembrolizumab in the adjuvant setting. Because again, I think based on the principles that you've described here, Tom, I think that, there's still, a role based on belzutifan for VEGF blockade. I think in the trials of yesteryear, we were just, doing it the wrong way with drugs that were too toxic. I think that, that Brad's trial is one that we should all sort of really rally behind.
Tony,
I'm going to add, then you ask me. So one of the advantage with Alliance trial led by Brad McGregor, who's here in the room, is that tivozanib is tolerated. And unlike sunitinib and pazopanib, you did not need to change and go to a lower dose that may have impacted the outcome. Just it's too much to have 800 in the adjuvant setting, where tivozanib at full dose, or sometimes it doesn't matter, it can be combined. Tivozanib can be, and even when you give tivozanib full, it's well controlled. So I think we should not miss on that possibility, and have another option with the first PD-1 VEGF TKI adjuvant study. You don't know what synergy does, and I think it's reasonable to continue. Pending what Hans said, we need to look at the data and see. Hopefully, we will be able at some point to present LightSpark 022 and look at the hazard ratio for OS.
Yeah, I think Strike is different. I think that, Brad's in beast mode, and he's accrued the highest number of patients to the trial to date. I think our site, led by our, surgical colleague who's here in the room, Wesley Yip, is second. I've been able to actually get patients through the 6 months,
We can.
without substantial difficulty.
Is the study viable?
Yes.
Yes, absolutely.
Yeah, but really, I mean, the truth is, so first of all, tivozanib is a great drug. I use it all the time. Okay, it's a great drug, well tolerated. I totally give you that. But the
I
truth
suspect
is,
there's a but coming.
the truth is, if he had now Bel Pembro, like who is going to use Tivo, whatever the other combining partner is? I mean, nobody will. So I think it's a trial of no consequence. I fear.
But what do you mean? In the frontline metastatic setting, or what are you referring to? Oh, adjuvant. Oh, no. I mean, I still think there's a possibility. I mean, you have to look at the signal.
Belzutifan and Pembro. You're going to use tivozanib.
I'd like to see the data.
Well, at least we know that with VEGF TKI and PD-1, there is no dampening of the immune response, like some of the study with HIF2 PD-1, which I don't believe because there are 2 times more doing the opposite. So I think it's very reasonable to go and support that study, and we have it open and it's enrolling.
Tony, biologically, you led a number of HIF programs, including the Casdatifan recent studies. What is the biological rationale? Do you agree with Hans on the biological rationale for HIF inhibition in the adjuvant setting and the principle of giving HIF inhibition? We've talked before, many of us, that the problem with LightSpark 05, it was the best way to get an approval because it's fast and heavily pre-treated and lots of patients, but it may not be the best place for HIF inhibition. And actually, it may be a really active drug, but much earlier. And actually, VHL disease kind of supports that. Where are you in your thinking about the sweet spot for HIF? And what is your opinion on the yin and yang associated with the benefits and the risk that Hans discussed?
So I'm not going to discuss biology because even if you talk to people that get Nobel Prize for this, it's impossible that they predict, what will happen. But I'm going to look at clinical observation. When you use Bel earlier and earlier, response get higher response rate, which is not the same with, let's say, something like nivolumab. And why is that? There could be multiple biologic hypothesis, less mutation, the tumor, do not have a lot of escape mechanism, et cetera, et cetera. But we've seen from 005 going to the data that Niraj Agarwal and Mike Atkins in LightSpark 013 that led post-IO response rate higher. Look at the VHL syndrome study, a bit of a different disease anyway, but in those patients that don't have metastatic disease untreated now, how much the response has, 70%, et cetera. So now I understand why the adjuvant could be positive. Not to mention the single agent activity of belzutifan only, irrespective of with being a PD-1 inhibitor or not.
Just before your question, Monty, but we're going to wrap it in 1 second. But someone came up to me in the bar last night and said they wanted to ask a question during the kidney cancer session. So if you do have a burning question, we've got time for one question. I'd love to hear that question. So do fire away if you've got anything particularly directed towards Hans, because that'll take 20 minutes to answer. Yeah. Sorry, Monty, fire away.
Oh, I was just going to say, Tom, I think a really important point, within this room especially is that, if we do see, this PFS advantage that's, reasonable with Pembro, Bel in the adjuvant setting, maybe not this overwhelming overall survival signal, it leaves the door open, I think, for, a number of adjuvant trials to move forward. I would say that's true certainly for Strike. There's so many other agents in the adjuvant setting that I'd love to see, pushed forward. We're going to have a conversation, I guess, in an hour or so about VEGF PD-1 bispecifics. I'd love to see Pembro go head-to-head with one of those. I really do think there's room for development unless we see that there's a slam dunk OS signal when you guys present the data.
I've been encouraged to draw a line on this, unless anyone's that burning question. Brian, you're lucky. The time is right. We can keep going. Many thanks. Fabulous discussion.
Oh,